Should doctors be allowed to conscientiously object to euthanasia? The question of conscientious objection in the medical profession has become particularly relevant with the legalization of voluntary euthanasia in many jurisdictions. While some doctors firmly believe that euthanasia is not part of medicine and have ethical or religious objections to it, others argue that it is their responsibility to provide safe and legally indicated treatments that are desired by patients. Patient autonomy is a crucial principle in medicine, but physician discretion and the ability to act in accordance with their best judgment are also important aspects of good medical practice. Conscientious objection allows healthcare professionals to opt out of participating in medical interventions that conflict with their ethical or religious beliefs. While it is often associated with controversial issues like abortion and euthanasia, theoretically, a doctor could have a conscientious objection to any medical procedure. However, conscientious objection should not be used to justify discriminatory beliefs or to avoid professional duties. Conscientious objection is not an absolute right and should pertain to specific procedures rather than classes of patients. Doctors who conscientiously object to certain treatments should ensure that patients can access those services safely and promptly through appropriate referrals. Respect for reasonable disagreement is an essential principle in liberal democracies, and it is pertinent to consider how it applies within the medical profession. While patients' rights and autonomy are important, doctors' right to conscientiously object should also be considered and protected. Striking a balance between these principles is a complex issue that requires careful consideration and dialogue within society and the medical fraternity. Physician objections to euthanasia arise from various ethical, medical, and regulatory concerns. Euthanasia, which involves intentionally ending a patient's life, is seen by many doctors as a violation of the principle of the sanctity of life. Some argue that it does not belong in medicine and go as far as invoking the Hippocratic Oath's principle of do no harm to oppose physician participation in euthanasia. Palliative care physicians contend that refractory pain can be addressed with appropriate analgesics, and hastening death goes against the ethos of palliative care, which emphasizes natural dying. Additionally, physicians raise concerns about the safety and proper regulation of euthanasia. Some worry about inadequate assessments for depression and the potential for patients with complex mental illnesses to opt for euthanasia due to a lack of social support. There are also apprehensions about suicide contagion and instances of unreported euthanasia cases in jurisdictions where it is legal. The permissibility of conscientious objection to euthanasia is a contentious issue. Reasonable disagreement exists among doctors regarding the risks and potential harms associated with state-sanctioned euthanasia. Concerns about inadequate regulation and potential negative consequences lend support to the idea that it is reasonable for doctors to hold objections to euthanasia. The debate over euthanasia represents a significant shift in the concept of medicine. Some argue that it moves away from a focus on health and well-being to prioritize fulfilling patient preferences, even if they are not conducive to health. The argument that euthanasia is a form of healthcare and thus falls under the right to access healthcare is questioned by some, as it seems to beg the question. There are concerns about the religious character of some conscientious objections, but distinguishing between ethical and religious objections can be challenging. Many doctors hold views that have both ethical and religious dimensions, making it difficult to separate the two. Arguments on both sides of the euthanasia debate often have a quasi-religious character, particularly when driven by concerns for human dignity. The regulation of conscientious objection to euthanasia varies in different jurisdictions, and there are ongoing debates on how best to address this issue. In some places, such as Ontario, Canada, doctors with conscientious objections are required to provide an effective referral to patients seeking euthanasia, while institutional conscientious objection is limited. In the Australian state of Queensland, faith-based healthcare providers cannot prevent doctors from assessing patients for euthanasia. Eligibility on their premises. It is essential to approach the regulation of conscientious objection carefully and thoughtfully. While some may view conscientious objectors as acting in bad faith, it is crucial to recognize that their concerns are often reasonable and deserving of respect. The shift brought about by euthanasia in end-of-life care requires careful consideration in its regulation. Accommodating conscientious objection in healthcare is a sign of a mature understanding of moral disagreement within society, and euthanasia is no exception. Recognizing the ethical complexities involved, individual physicians and institutions should be allowed to opt out of participating in euthanasia without facing punitive measures. Authentic liberalism in healthcare means respecting the values of doctors and institutions, while also prioritizing patient interests.